Welcome to another episode from the Veterinary Research Channel. Today, we delve into a fascinating case study published in the Journal of Veterinary Internal Medicine in 2024. This report explores the unusual occurrence of spontaneous remission and subsequent relapse of diabetes mellitus in a male dog, offering valuable insights into the complexities of this condition in our canine companions. Generally, in veterinary medicine, particularly when discussing diabetes mellitus in dogs, the prevailing understanding is that once diagnosed, the condition typically involves a permanent and absolute deficiency of insulin. This is thought to be primarily due to the loss of the insulin-producing beta cells within the pancreas. Therefore, the expectation is usually that dogs diagnosed with diabetes will require lifelong insulin therapy. However, this case report presents a compelling exception to this rule, documenting a period where a dog's need for insulin completely resolved, only for the diabetes to return later. While such remissions are more commonly observed in cats and humans, particularly in association with specific physiological states like pregnancy or the estrus cycle in female dogs, they are considered rare in male dogs without such identifiable triggers. This study highlights that the dynamics of diabetes in dogs might be more intricate than previously assumed, even in the absence of obvious reversible factors. Let's delve into the specifics of this intriguing case. The patient was an 8-year-old male neutered miniature schnauzer who presented to his primary veterinarian with a 2-week history of increased thirst, known as polydipsia, and increased urination or periuria. These are classic clinical signs associated with diabetes mellitus. Prior to this presentation, the dog had a history of seasonal allergic rhinitis, obesity, reaching a maximum weight of 13.5 kilograms, and thunderstorm-associated anxiety. Interestingly, the dog had previously received tapering courses of a corticosteroid medication, methylprednisolone, for his allergic rhinitis, with the last dose administered 18 months before the diabetes diagnosis. While on this medication, the dog had exhibited elevated levels of an enzyme called alkaline phosphatase in his blood, mild elevations in fasting blood glucose, and mild elevations in fasting cholesterol. 6 weeks after stopping the methylprednisolone, these values had decreased. At the time of the diabetes diagnosis, the dog was not receiving any medications, and recent blood work was unavailable. A physical examination revealed dental tartar and gum inflammation, but no other significant abnormalities were noted, and the dog's body condition was considered normal at a weight of 10.3 kilograms. Initial blood tests confirmed hyperglycemia, meaning high blood glucose levels, at 401 milligrams per deciliter, significantly above the normal range of 60 to 110 milligrams per deciliter. Alkaline phosphatase was also elevated. A complete blood count showed an increase in a type of white blood cell called neutrophils and a decrease in lymphocytes. Urine analysis revealed a low specific gravity, indicating dilute urine, a neutral pH, the presence of glucose, a condition known as glucosuria, and some protein or proteinuria, but no ketones. Based on these findings, which aligned with the agreeing language in Veterinary Endocrinology consensus definition, the dog was diagnosed with diabetes mellitus. Treatment was initiated with twice-daily subcutaneous injections of a type of insulin called neutral protamine Hagedorn insulin, at a dose of 6 units, and a therapeutic weight management diet. Over the following year, the dog's insulin requirements gradually decreased. Regular spot checks of blood glucose concentrations indicated that his blood sugar was often within the normal range, a state known as euglycemia or even low, referred to as hypoglycemia. Based on these readings, the insulin dose was progressively reduced and eventually discontinued entirely. Remarkably, after stopping insulin therapy, the dog remained free of any clinical signs of diabetes for a full year. During this time, a blood glucose concentration measured 8 months after discontinuing insulin was within the normal range. This period met the criteria for diabetic remission as defined by the agreeing language in veterinary endocrinology, which includes the absence of clinical signs and no evidence of diabetes for more than 4 weeks after stopping insulin. However, this period of remission was not permanent. Approximately 1 year after insulin was discontinued, the dog was again presented to his veterinarian with a recurrence of increased thirst and urination. Laboratory analysis confirmed a return of hyperglycemia with a blood glucose level of 486 milligrams per deciliter and glucosuria again meeting the criteria for diabetes mellitus. Ketones were absent in the urine and the urine-specific gravity was relatively high. Insulin therapy was restarted at a dose of 5 units twice daily. Over the subsequent year, the insulin dose had to be steadily increased, reaching 17 units twice daily to manage persistent high blood glucose levels. Despite these efforts, the hyperglycemia continued. Sadly, for years after the initial diagnosis and 2 years after the relapse, the dog experienced a cardiopulmonary arrest while under anesthesia for a dental cleaning. A necropsy was not performed to further investigate the underlying causes. The occurrence of spontaneous remission in this dog challenges the traditional view that canine diabetes mellitus invariably involves an irreversible and complete loss of insulin production at the time of diagnosis. This case suggests that in some instances there may be fluctuating factors affecting the function of the pancreatic beta cells or the body's sensitivity to insulin. While no specific underlying cause for the remission could be definitively identified in this particular dog, the report discusses several potential contributing factors. The dog's history of obesity and previous corticosteroid therapy are known risk factors for insulin resistance, a condition where the body's cells do not respond effectively to insulin. Additionally, the recent feeding of table scraps, which can be high in fat, could have also contributed to insulin resistance. Miniature schnauzers are also known to have a predisposition to high levels of cortisol in the body, a condition called hypercortisolism, which can also lead to insulin resistance. It is plausible that a combination of these factors initially contributed to the development of diabetes. The subsequent weight loss of over 15% of his body weight at the time of remission likely improved his insulin sensitivity, potentially allowing the remaining beta cells to function adequately without the need for supplemental insulin. Weight loss has been shown to improve insulin sensitivity in dogs. However, the fact that the diabetes relapsed a year after insulin was stopped suggests that the underlying issue with the beta cells was not fully resolved. The report also considers the possibility of glucotoxicity, which is the damaging effect of persistently high blood glucose levels on the beta cells, leading to further dysfunction and death. In humans with type 1 diabetes, a temporary remission known as the honeymoon period can occur shortly after diagnosis and the start of insulin therapy, potentially due to the improvement in beta cell function following better glycemic control and resolution of glucotoxicity. It is hypothesized that early and intensive insulin management might help preserve some beta cell function in both humans and cats, increasing the chances of remission. In this canine case, insulin therapy was initiated relatively soon after the owner noticed clinical signs, which might have contributed to the initial remission. Dietary management is another important aspect of diabetes control. The dog was transitioned to a therapeutic weight management diet, which was high in insoluble fiber. Diets lower in carbohydrates and fats and higher in insoluble fiber can help slow down carbohydrate absorption, reduce post-meal hyperglycemia, and improve insulin sensitivity in dogs. While the high fiber content of the diet might have contributed to better glycemic control, the inconsistent reporting of the amount of food fed makes it difficult to definitively assess the role of diet in the remission and relapse. The report acknowledges some limitations, including the lack of comprehensive glucose monitoring, such as glucose curves or measurements of glycated proteins like fructosamine or hemoglobin A1C during the initial period of diabetes. These tests would have provided more detailed information about the degree of hyperglycemia and the effectiveness of treatment. Additionally, advanced abdominal imaging or a post-mortem examination could have helped identify any underlying pancreatic issues, such as pancreatitis, which can be associated with diabetes in dogs, or evidence of hypercortisolism. While the dog had risk factors for pancreatitis, including eating table scraps, there were no acute clinical signs to strongly suggest it. The unusually dilute urine at the initial diagnosis also hinted at the possibility of another underlying condition contributing to the increased urination. Despite these limitations, this case report provides valuable evidence that spontaneous remission of diabetes mellitus can occur in male dogs without obvious hormonal influences, although it appears that the underlying susceptibility to the condition may persist, leading to relapse. This highlights the need for continued monitoring even after a dog appears to have gone into remission. Further research is needed to better understand the mechanisms that can lead to diabetic remission in dogs and to identify potential predictors of this phenomenon. Thank you for listening to the Veterinary Research Channel. A link for the referenced paper is in the video description. Remember to test your knowledge by answering the questions in the description, and as always, keep those minds inspired, hearts light, and tails wagging.